Right, so now that we have intake notes on the intake template, we'll move into the SOAP, and this is where you'll start. The results reviewed for your results of records or imaging, it's also in the SOAP, or the HPI template rather, and that's the same. We're keeping that the same. It works for us. We're keeping about 10. We have our custom templates to 10 currently, which is a nice number. It's a workable number. But we'll go through the SOAP template here. Again, the panels link with the intake note. I think we've talked about this before. So the top 4 panels or so are feeding directly from the intake. So not a whole lot of documentation that needs to be done as far as these panels are concerned after the visit, which is where we're currently doing all of this. It's all done already, and where the assistant kind of will start their documentation with your encounter is really with the exam. But we'll go through these again here. So the general will fill in automatically. Reason for visit, HPI. A lot of times more things are discussed when the provider's in the room. You can go back in. This is the exact same template. You can edit this if you'd like. There's also these intake comments that you can use to type more pieces of the HPI. That populates at the end of all the HPI. So I'm not sure if that's something that we're going to want to use because it kind of messes with the formatting a little bit, but it is an option. The review of systems, it's pulling right in from the intake, and the vital signs would be pulling in as well if I had put any in here. So the physical exam. The biggest difference with the out-of-the-box physical exam versus the one that we're currently using is that they have these one-page exams. And let me show you what I mean by that. So there's 2 of them. That work for us essentially. This is their generalized 1 page. It covers the whole body, so it has a lot more than what we necessarily need. Our column is basically this left is kind of everything that we use, and then a little bit over here. All of these little words is active text leading you into bigger templates for more documentation. But it is kind of nice that it's all in one place. It feels like there might be a lot more clicking because you're going in here, but it is actually less. There's also this sinusitis 1 page that I found, which is basically everything that we only look at. Again, these words, you can go in farther to open up the templates more. So there are these 2 1-page exams, which are pretty slick, I think, because you can kind of see everything. It's most of the pertinent information. Much like the review of systems, we use these quick saves to kind of throw in a lot of information and then document by exclusion. Like I mentioned, that's what we're currently doing, so that's not anything new. But I'm definitely going to encourage that being something that we do moving forward, just because it makes sure that we do have all the right information, and it's new templates, so it's kind of vital that those are used. But we'll just go in here and go through them quickly. The constitutional, these are the only 3 buttons on the actual constitutional template, so I won't go in there. Eyes is pretty extensive. There's a lot more in here that we can document. Ears also has a lot more. This is where we document the pneumatic otoscopy, tubes, hearing. You'll see this a lot, so the system really maps out any kind of masses for us, which is nice because it puts them in this neat little grid format to really make them consistent across the board. This is pretty much the only template in here that I don't necessarily agree with, the nose, mouth, and throat, because it's combining everything onto one. And I think that the mouth template doesn't have very much on it because of that. There is an oral cavity template that we can talk about using. It's not linked to the billing. I can't explain why. I think it might be an old one, but it's a lot more detailed. And if that's something that you're interested in using, we can. We can also configure any of these things to kind of read differently. But believe it or not, this template does cover all of the billing elements for the ears, mouth, and throat. So it does cover that side of things. It's just more along the sides of documentation of whether or not we want to, comment any farther. So I'll just pick a few things here just for the demonstration's sake. Let's just keep going here. And all these pick lists rather have been adjusted to be the same ones that we had in our original system. Neck and thyroid, again, has these kind of mapped out for masses. The neck mass templates, I think it's kind of cool because you can, once again, really lay out where anything is, and it grids it out kind of. And when I say grid, I don't mean like what you see previously. It makes it really clean in the note, having it be in the documentation this way, and we'll make it so that it's all the same across the board for every assistant. The lymph system, we don't really use that except for new patients, but it is linked with the neck, so some of these are pulling over from the neck. And if you ever comment on any other, it's kind of the same piece. This on the side, you'll see a lot of body groups that we don't really cover, but they are linked to that generalized one page, so that's why we have them all. So they're there if you ever want to document on them, I guess, but we just kind of learn to ignore. At first it seems like a little bit annoying to have them there, and eventually it tends to not be that big of a deal. There are a few templates on here that I think Dr. Boudel might be able to use for some of his documentation. The skin and hair one might be something that he can use for some of his documentation. And the neck and face has a little bit more than what we currently have. You can comment on, facial bones, eyebrows, facial features. So that is something for him to keep in mind. There's one last one that I want to show you, and that's the cranial nerves. So the neural template has, once again, everything that we document on. The cranial nerves template is really cool because it lays out all of the cranial nerves for us. And, say there's one side that's, I don't know, that probably makes no sense, but one side that's different from the other or something like that, you can change them, and it's pretty cool. I personally think it's cool, especially since it tells me what all the nerves are, and it just kind of graphs it out really nicely. And once again, it's a consistency thing. So we'll go back and just click the button here just for the sake of the demo, but I do like that neuro template as well. So we'll save and close here, get out of that. And all that information is also on this one page. It's more just whether or not which of the two we prefer for our documentation, but this one page surprisingly has some more information than the other one page does that we need, and then a lot that we don't need, so it's kind of a little bit of a toss-up. So that's why I kind of kept it in here, but just so you know. So that's the physical exam. The assessment plan is pretty much the exact same of how it is now. I don't know how many of you go in here ever. Well, you would to document or to adjust the assessment plans, I suppose, but you add in the assessment plans from either the common assessment one page. Now this is configured in production, it's a lot nicer, but in test it's not. I didn't really do it in test, but this has all of the pertinent common assessments on it, and you just click on it and it adds it down. But you can also add it from, this is the billing history, this is pulling from that problem list, and this is pulling from like your own favorites. These are ICD-9 codes, however, so it's not recommended to pull from there, but they are around here. So let's just pop in just a few, just because. And then, okay. So the My Plan is really messy. I wouldn't even recommend clicking on it because it's just, I don't think it's a very useful template. Here's what the assessment plan details looks like. Pretty similar to the one that we use now, with the exception of the fact that there's a few more boxes. There are my phrases to make documentation easier, common phrases, all sorts of things. In an ideal workflow situation, the assessment plan would be something that you type in, just so that we're not, going back and it's just in there once. It's how you want it. It's not something that has to go back and be changed or added. It's not written more than once. It's just a one-time thing. I know that's pretty significantly different than the workflow that we're currently doing. I think it's been working pretty well for Dr. Rudell, but I know that's just a big change, and I understand if that's not something that we end up doing, but that would be it would be an ideal workflow for us to get things in efficiently. So this is where your plan goes. This provider details doesn't go in the note, and differential diagnoses. So, excuse me. So these are the same as how it is now, and they pop up here just like how they do now. Going back into this template, just FYI, the labs tab opens the lab module, which is kind of nice to get to. If it wasn't so slow. So this is exactly what the lab module looks like. So if you ever want to review any labs, that's a place where you can see what was ordered. We won't use diagnostics. That's more for if you have, in-house imaging, which we don't. Referrals is a nice way to send out referrals to different doctors. You can even, attach a document to it. So you could attach this current note to that referral and fax it directly from the system to their office. And then they have all that they need for this referral, including an official referral form and the note. And we could send more. I could send I could attach as many documents as I want. This is kind of where the attachment piece is. Office procedures. This is where we'll document injections, catalog, and Botox, medical Botox. What's nice about this is that you can enter in, all of the expiration, lot number, etc. here and location, and you can bill right from this. So if you click performed and you save and close it, it sends it to the billing. So it's nice because for nurse-only visits, sometimes those catalog injections could get lost in the billing themselves, or it's kind of something that is a little bit of a nuisance to go back to even. It gets sent right away. Same with in your encounters, so sometimes those don't necessarily get caught and billed for, and this makes it automatic. They will always get charged for those. The medical Botox is a little bit different. I know that we are figuring out that procedure there, but I did put it in here as an option just to cover the bases there. And then co-signing orders, we don't really use the signing of the orders, but if that's something that we ever want to implement in the future, we can certainly turn that on where you have to sign all the orders that we place, and this is where you would co-sign them. Or sign them rather, sign off on them. So that's what the assessment plan looks like. Let's go into the procedures a little bit. This is where I would argue the majority of our custom templates are remaining, just because a lot of them work for us. I have made some adjustments to our custom templates to make them a little bit more streamlined. Dr. Tedford's is a good example. Your scope will still read like how it does now in a paragraph form, but this is just a little bit easier for the assistant to document because it's more of what they're used to with the other providers, and it'll pull it in the same every time. Or it'll pull it in the same format, so it'll make training a little bit easier, to be honest, because one of the hardest things is that, it's not letting me move it because I have some required billing fields on here. That's another thing that I'll get into in a minute here, but it'll streamline your scopes a little bit more, which I think would be kind of nice. So here's Dr. Getnick's, and this is also the template that Dr. Rudell has been using. We added a few more things on here, adhesions, frontal sinus, etc. What's nice about the out-of-the-box templates, which I've implemented on our custom templates, is that you can bill from the procedure, and it kind of takes care of it. It's gone. If it's a procedure-only visit, you don't have. You're already done by the time you've written the note. I've put a lot of triggers on this template and Dr. Tedford's template as well, so that hopefully, wrong procedures don't get billed, but you can go back and change what was billed. So I can show you a little bit about that. We'll look into that right now. So let's just go ahead and document this. kind of how you would if you were seeing a patient. Let's just kind of say that. Da-da-da. Cool. So I can't close this template without filling in the rest of these, without filling in any of the rest of the documentation on here. So I'll go ahead. You saw that in the last one. I was just kind of fumbling around on his template, and it was like not letting me leave because everything was blank. That's kind of our way of saying, you know, you have, where you're billing from this template, you have to finish this off. So we'll just put in a diagnosis code. So these modifiers fill in automatically. And the way I have these set is if there's documentation in here of the sphenoid, it'll change this to being, you know, a sphenoid scope, and it'll automatically change the CPT, with the exception of unable to visualize, and then that'll knock it back. Same with debridements, it works the same way, and same with fiber optics as well. So I've thrown on a lot of triggers, and it's just going to kind of have to come with time to see if it's weeding out. But if the assistant doesn't choose the correct procedure, hopefully the system will choose it for us. So we'll submit this off to Superbill, and you can only submit it once, which is also something that I've heard has been a little bit of an issue in the past. Our current template will let you kind of send it unlimitedly, and then there's just like a ton of charges, and if they get sent off, it's a little bit of a mess I've heard from the billing side. So I mentioned previously that you can look at those, and that is in the Superbill under File, and this is that charge for that service, and you can adjust it here. And if it's already, you know, if it's something that is you can't figure out how to adjust, or if it's something that we can't get to adjust, we can have Maria take care of that, or we can figure it out. But here's your diagnosis codes for this procedure, and you can adjust as needed. We also talked about a lot of the out-of-the-box procedures and how it's kind of, you know, a little bit more minimal documentation on our side. And the nice thing about it is that they are a lot easier to use, and they are a lot easier to train on, because it's some of these procedures that we never see other than, you know, once a year someone will come in, say you have one peritonsil abscess a year, and that happens to be the one time that you see that patient. I mean, it's hard to train on absolutely every instance, and a lot of it is repetition, and if you only do it once, some of those templates are harder. So that's where I think these out-of-the-box templates are so beneficial, is with training time. An example would be cerumen. Now, granted, the cerumen is, our out-of-the-box one is pretty easy, but it is a lot of typing, and it takes time. So this is where a lot of the ear procedures occur. Really easy to document cerumen impaction. You know, you just choose what they used. You can't close without a diagnosis code. So we'll go ahead and search for one. Actually, the search kind of slows it down. In production, I have these folders and categories set up, but I don't have them set up in test. We'll pull in the diagnosis. It's going to ask for a side. It's going to throw in the modifiers and everything that we need. We can click if anything was obtained. We want to talk about follow-up here, you can. This is where we'll document that it was normal and that they tolerated it well, and I'll submit it off to Superbill. So now this is being charged for, it's taken care of, we can save and close. So that's kind of one of the reasons why, and you'll see how it pulls into the document, but I just think that it's really fast documentation, and it's pretty easy to train on. Results review, this is the same custom template, so it functions the same. Provider letters is how we send off letters to providers, is also how we're currently using it. And order management is where we document, you know, results and that kind of thing. Surgery scheduling, we're going to keep the same. Oh, one thing that I didn't mention for the assessment plan piece is that's where our DBR was. I've saved those all as my phrases. So although we don't have the same HPI template, or rather, the DVR template, just because customizing this is an enormous undertaking, and we've been highly recommended not to. But I do have them saved as my phrases here. And so they pull in, exactly how they do in our current system. All that the assistant would have to add is, wishes to proceed or something along those lines. The biggest downside is it doesn't pull into the surgery template, and currently they're linked, but a lot of times we have to go in and adjust them anyways, so it all kind of works out. This is the exact same, so that doesn't change. It works for us. The surgery schedulers know how to use it, so that's something that we're going to keep the same. Also to keep in mind is sometimes if there's a procedure, like cerumen impaction is a great example where it's not pulled into the assessment, this will automatically, because it's linking the assessment code, put it in the plan, documenting that you did that procedure, and it all will link in for you. So it kind of does a lot of things automatically for us. Documents and letters, so these are kind of where you can do all of the letters or any kind of document that you need, including summaries. Kind of nice, kind of fills it in the same, left all of these pretty much formatted exactly how we have them now, which will be good. Hopefully with the workflow, keeping workflow in mind, this is something that can be generated, around the time of the note being generated. It can be reviewed, adjusted, and sent off. This will eliminate printing all of them, we currently print the note. This will eliminate hopefully printing the note to be done, maybe eliminate or reduce Clay's stockpile a little bit, and we can talk about how we want that workflow to work, but it's kind of nice that they offer, there's even a lot more documents. I've cut this down quite a bit, but it's kind of nice that there's a lot of options there for us, and it'll make providing the patient with any kind of formal letter or anything in the visit a little bit more uniformed. And finalized template is the newest template for us, and this is where all of the billing kind of goes down, essentially. We talked about how it picks the code for you, and I'll show you how that works. First, you choose the general, which pulls in automatically, and here are your assessments, and you can sort them in the order that you want, keeping in mind that E&M coding the order does matter. Provider sign off, we don't use that because you don't sign off on any of your orders. And this is where all of the E&M coding occurs. Basically, all that the system is counting all the points, and you just choose the MDM level. So say I think that this is a low complexity visit, and I click calculate code. It's going to pick the code that works for the encounter. Once again, it's just slow because it's in test. It's not usually this slow. It's going to pick the code based on the encounter type, the type of patient, new or established, the points from the HPI template, the points from the physical exam, and the MDM level that you choose. Based on so it's pulling in the points, and then it lets you look at them, which is kind of nice, so we can see what we're missing, where we need more points. So this is showing us that this is a detailed exam, which is our established patient exams are detailed. This is telling me that I have 4 points from my HPI, and this is where they're coming from. So if I wanted to get more points, I would have to document on timing, severity, quality, or context. The chronic conditions from HPI from today's assessment, that goes back to the problem list. If we mark them as chronic and they are in the assessments, it'll give you some points there. This is past medical history, and this is review of systems. Let's drop down. Here's your physical exam points. So this is telling us where all these points are coming from. We obviously don't talk about these, but it's pulling in from what ENT needs. So these are exam elements. 23 is a comprehensive exam, and then the shaded border is what we need to get billed for a new patient. So it's kind of nice because it lets you see where you're not met, where you haven't met the level of the MDM level that you want. You can override it if you want, but I've tested this with a lot of different with a lot of different scenarios, and it's picking the right code. It's accurate. It's just it links with the documentation, and if you're not documented high enough, it's not going to choose the right code, but it does. We can also comment on total visit time, and if you do type for a time, there's some of those long visits where there's a lot of consultation time, it will code for time, and you will get compensated higher. Excuse me. It pulls in post-op codes that are in global, and it'll bill for post-op because it links with PM a little bit to know where someone is in their global period, and you choose the post-op encounter. And like I said previously, if it's a procedure only, which happens a lot with like cerumen debridements, or sometimes they'll happen with like a trach change, it will you just don't go to the finalized template essentially. So you'll submit the code. You can only submit it once. You'll kind of see a little red code submitted pop over it, so I can't go back in again, which once again will be nice for the business department. And submitting the code automatically generates the document. You can generate the document the same way we previously have been, but this does it automatically. And so now we're at our clinical note, our master IM. History of present illness, so this is pulling in just like your intake note. You have your associated positives and negatives here. Here's that same problem list that we talked about. If you notice, I made that change previously, and there that is for us. Past medical history, so this is where we put in what they write on their history form. Same with social history. Medications, review of systems, physical exam. So we've put the physical exam, I've tried to mimic it as closely as how it looks now. There's a little bit of some separation of left and rights for the ears and the eyes, and a little bit in the nose, but we've tried to keep it pretty much the same. If you remember, we bolded anything that's not normal, so that's where you'll draw your eye to what's not normal, just because having the normal written here or not having normal written there is a pretty complex coding, or not coding, but configuration, and something that's way over my head and would take someone from the outside to figure out if that's something we ever want to go through. But this is what kind of the physical exam will look like. Procedures pop in here for us. This is what if you remember, it was like 2 clicks on the cerumen debridement, and this is kind of what pulls in here, which is nice for us. Here's Dr. Getnick's nasal endoscopy, and our current template separates left and rights. We can leave them as bilaterals here, and that is hopefully pretty close to the same for you. An assessment plan, it's pulling in the assessment plans that looks the exact same. I did ask about taking out the assessment code, and unfortunately that, just like adding in the normal for the physical exam, it's an enormous undertaking. They always say that they would never say never, but it would be an enormous undertaking and would take a lot of manpower, and they basically alluded that it would be kind of a pricey endeavor if that's something that we are ever interested in the future. But it's kind of in SQL encoding. So that's kind of what your master IM or your clinical note would look like using the new system. Hopefully it looks pretty much the same as what you have now. There are a few changes, but most of the changes I've tried to make on more of the clinical assistant side versus your documentation side. And that's what we are proposing for a patient encounter.